I'm Alicia Gonzalez. I am an emergency medicine doctor at ICU. I have the great privilege of being the person after lunch. So I just appreciate all of you being here so much. I definitely have a lot of energy. Hopefully that will keep your attention. And we're going to talk about drugs. So hopefully that's an interesting enough topic. It'll also hold your attention. So thank you so much for being here. As mentioned, I do work for the California Bridge program. California Bridge was actually established by the state of California. We are funded through the Department of Healthcare Services, fully nonprofit. I don't have any financial disclosures. If someone would like to pay me, let me know. But I might say brand names, not because I'm loyal to any, but because a lot of the words that are brand names are what people know in the community. So for example, if I say Narcan, I think a lot of people know what Narcan is. If I say naloxone, not everybody feels as confident with that word. So please don't mistake me for being big pharma. I am not. But I do sometimes use brand names for simplicity. But I have no financial disclosures. The state, through a nonprofit grant, gives us money to be here. So, what is California Bridge? California Bridge was part of the state opioid response program. How are we going to address all deaths from opioids in California? And so they started this organization, they got a bunch of doctors and some really cool public health people together, and we went around ER to ER throughout California. We are currently operating at 280 of the roughly 300 hospitals in California. In healthcare, this is a massive amount of progress in just 5 years, by the way, massive amount. Teaching doctors there how to do better substance use treatment for their patients, very specifically out of the emergency department. We see a ton of patients who use drugs coming in and out of the ER for various reasons, sometimes drugs, sometimes infection, sometimes the flu, whatever. But we often are missing the root cause of their problem, and so we go around and help doctors learn the most up-to-date evidence-based care to elevate that ability to start those patients in care and then connect them to care in their community. We're really proud of that. And why are we doing that? This is not a graph that is a surprise to anybody, I can guarantee that, right? But this is showing you the rate of rise of death from drugs. This is all drugs, by the way, from 1999 until now. And if you were to do some simple math, you would see it's a 9-fold increase. And actually, this goes through 2021, where it topped off like 106 to almost 107,000. As of 2023, it's surfaced higher than 113,000 deaths in the U.S. So you can see why, maybe we weren't talking about it in the 90s, but we are talking about it now, is that in the 90s, it wasn't killing everyone. Drugs are killing everyone now. And of that number, if we look at what the number one cause, the answer is opioids. So today we're going to talk about a lot of different substances, but I am going to keep coming back to opioids because this is the one that is actually killing people. And it's killing people of every age, every gender, every community. It does not discriminate by income or class or any of those things. It's really a universal problem, and it's really rising. When you separate out those deaths in general by substance type, what you see is the purple bar that's going way up high, that is fentanyl. Synthetic opioids / fentanyl. We'll talk a little bit about what fentanyl is in a second. The next highest, believe it or not, is actually going to be methamphetamines. Is the second highest one. It's a lot lower. Opioids is the huge majority, but then methamphetamines, cocaine, still around and living large, and then opioids by prescription is the yellow line. One thing I am proud of is that you'll notice the yellow line one is the only one not skyrocketing. Doctors have really taken on a huge amount of effort to stop prescribing as many opioids when we don't need them, but I will own soon in this presentation that it is our fault that this started. That's a really big part of this conversation. How is it our fault? Wordy slide. You don't have to read it. Let me break it down. The opioid epidemic is very complicated. How we got here is complicated. But it can be distilled down to a couple of extremely key moments. In particular, somewhere around 1986, there was this publication, the Journal of Pain, that came out with this new, improved, incredible opioid called OxyContin. And Purdue Pharma and the Journal of Pain put out this article saying that the new opioids are safe and effective, and I quote, "No American should ever have to experience pain again." This is what we were told. This is the science. I love number 1 on this Rotary rules, by the way. Is it the truth or is it pharma? But at the time, we didn't know it wasn't the truth. It was pharma. Yeah, it was number 2. Ding ding. So unfortunately, we didn't know that. I mean, doctors used to be in cigarette ads too, right? Things do change over time. We get smarter, but we didn't know. And so we started putting everybody that came in the ER. You have ankle sprain, OxyContin. You bumped your elbow, OxyContin. You got the flu, your chest hurts from coughing, OxyContin. Everybody was getting opioids. And then as we moved forward, what happened more into the 90s is that they started to add pain as the 5th vital sign. Have any of you heard of that before? Yeah, the 5th vital sign. What's your heart rate, your blood pressure, your temperature, your respiratory rate, your oxygen level, and what is your pain 1 to 10, right? It was that important. And then it got embedded into our patient satisfaction scores, as in doctors literally lost money if patients didn't say their pain was well controlled when they were at the hospital. So we were financially motivated to take all of your pain away, and nothing does that like an opioid. Nothing does that like an opioid. Simultaneously, while this timeline is going forward, black tar heroin enters the United States from Mexico, right here in San Francisco. Add that to the list of fun facts about this city. But it's not San Francisco's fault. It spread rapid fire. I mean, this stuff like flew around like candy, and now it's everywhere. And so even though we were just like giving this stuff out all the time, and adding financial pressures to do this, illicit drugs were also taking over, and we had this like massive explosion. And as this is going on, and we're literally financially incentivizing doctors to give out these pain medications, opioids become the #1 killer of Americans. And here we are. Said a little bit differently, there are a lot of factors though that led to this. So we have like the big pharma marketing, that was a huge one. But now, opioids are still on the rise, right, doctors? But we woke up to this. We figured it out. We had decreased our prescribing by a ton to a much more appropriate level, but people are still dying. Why is that? Because the problem is so much more complicated. A lot of our patients don't have good access to care. So many patients who live in poverty or who are immigrants or who are undocumented don't have good access to care, but they have pain. We just heard another speaker talk about all the kinds of pain, right? Not all pain is physical pain, but all pain feels better with opioids, at least temporarily. And so we see a lot of people trying to find access to care and to treat whatever that pain is, and a lot of them turn to drugs. Pharma marketing, like I had mentioned. The supply of heroin, now fentanyl across the US, it's cheap. It's so easy. I bet you, any of you who've never tried to buy drugs, you could. It's not that hard, I promise. If you went out there and just kind of said it loud enough on a street corner, somebody would find you. It is so shockingly easy. Snapchat, it's like so easy to buy drugs right now. And then you add in COVID, holy moly, and everyone's stuck at home and isolated and alone and doesn't know how to cope, and like substance use just skyrockets. And so it really is a really complicated problem. And that is why we have headlines like this on the Los Angeles Times in the fall, that there was over 1,000% increase in people who died from opioids. And so we talk about all substances. They're all important to talk about. But we talk about opioids the most because this is alarming. And this is so sad. And we can't ignore it. When we talk about all drugs, though, I mean, I know one of the big themes of today is kind of bringing conversations to light that we're afraid to have. Did you know that almost half of American adults know somebody who died of an overdose? Not just like heard about it around the corner. They know somebody. That means half the people in this room know somebody who died of an overdose. This is not like, again, siloed into one community. This is an everybody problem. This is a nationwide problem. And so we have to do something about it. I'm gonna take a moment to level set because I don't always assume that everyone knows what the heck I'm talking about when I throw around medical words. So opioids, when we say opioid, and you'll notice I'm not saying opiate. We don't say opiate. That's like actually only a subset of opioids. So opioid is the correct big family word. Opioids are drugs. Some of them are natural, like opium. This is a picture of opium, the opium plant, which is actually very common in like more Eastern medicine. It's a very like used to be used as part of like natural medicine back in the day. But all of the opioids share the same chemical base structure as opium, the plant. And of course, we have some more naturally occurring types. We have lab-oriented types, but they all work on the mu receptor or the opioid receptor in your body to cause you to feel good. They cause euphoria, they take away pain, and they're actually super important in medicine. Thank God, after you break your femur or you get a kidney stone, that we have morphine. This is a good thing. We want to have this. However, at higher doses, it can cause people to slow their breathing, become altered, and overdose. So really, really dangerous. What's the deal with fentanyl? I actually gave a lecture once called WTF, What the Fentanyl? It was very popular. But why are we always talking about fentanyl now? Well, fentanyl was made on purpose, like by scientists in a lab. We needed better opioids that didn't cause people's blood pressure to drop. And some of the ones we have used to drop your blood pressure. And so we'd have patients with like, say, cancer, really bad cancer, and they would need pain control, but the ones we had, we were like dancing around these low blood pressures and they had the other side effects and whatever. So we made up fentanyl in a lab and it's awesome. It works really, really well. It's in micrograms as opposed to milligrams, which means it has a
very high potency. A little tiny bit of it does what a lot of morphine does, or what a lot of heroin does, or a lot of Dilaudid, hydromorphone does. So fentanyl is extremely powerful that way. What's bad about that is that you only need a little bit to cause big problems, and it made it really easy to put fentanyl into all the other drugs. And so one of the reasons we talk about fentanyl all the time right now is that all drugs are fentanyl. If you meet somebody who does methamphetamines, they also do fentanyl. If you meet somebody who does cocaine, they also do fentanyl. If you meet somebody who does heroin, it's also fentanyl. Everything is fentanyl, period. Like, it is very, very, very hard to find quote unquote clean, I don't like that word, people say it, clean drugs or pure drugs out there. Almost everything has fentanyl because it makes you feel so good, even with such low doses, that dealers want you to like it. They want you to feel the sudden euphoria that fentanyl causes, so it's basically pervasive. And you'll have patients who don't realize that they have opioid dependency because they think they've been using a stimulant like cocaine, but also for months without realizing it, while they're using cocaine, they're also using fentanyl. And so now we have dual problems, or people overdosing without realizing it. So that's the deal. And the DEA does track that and has found it all over. It only takes a tiny amount, like I said. 200 micrograms, by the way, in the ER is a really, really big dose. Like 50 micrograms is normal, or 100 micrograms. Drug trafficking is by the kilogram, right? So 1,000 times more than that. And if you took 1 kilo, which is like not that much to physically hold, it could kill 500,000 people. And so that is why fentanyl is killing Americans, because it does not take a lot to have really, really bad effects. When we talk about drugs in general, I also want to clarify a couple of words. So the reason that substance dependency or all of that matters is because in our body, certain substances physically change how our body actually operates, meaning how it feels normal. And so when we say tolerance means, like people say, I have a high tolerance for alcohol, right? If you stop, my friends who have a high tolerance, they get pregnant, when they come off maternity leave, they don't have a high tolerance anymore. It goes away, right? Your body builds tolerance when it's exposed to something over and over. That means it takes more of it to have the same effect that it did when you used to have a little bit. Like, I'm a cheap date. Well, then you're not a cheap date because you have tolerance, right? That's what tolerance says. If you do that with enough regularity, you can develop dependence, meaning your body cannot physically feel normal without some of that substance in your body. So when you don't have it in your body, you enter withdrawal. You'll notice so far I haven't said anything about addiction. Okay, because not all dependence is addiction. There are plenty of people who have alcohol use disorder or opioid use disorder who are dependent on it, have to have it in their body, but have like solid jobs and functional families and important relationships and are very well educated in all these things, right? So addiction is actually a term that has to do more with like the psychosocial aspects of what substance use can do. Ruining relationships, interfacing with the criminal justice system. That's how we define it. So I just wanted to really clarify that you're not really going to hear me say addiction in most of this lecture, because addiction is a word that is filled with stigma, and it does not include a lot of people who have something more along the scheme of substance use disorder. Even people with addiction have a substance use disorder, right? It's not going to be the most perfect thing in their life, but we don't say addict. We don't say junkie. You know, we didn't call Whitney Houston and Elvis Presley junkies. We only call homeless people junkies. Right, so we just avoid language like that really belittles the human being who's going through all of those big dots of factors that led them to their substance use, and instead we talk about their substance use, because we also know, all the more recent literature shows us overwhelmingly that substance use disorder is a neurocognitive process. It is a diagnosable medical problem for which there is actually evidence-based treatment and care. We don't really go around to people with diabetes and be like, that insulin-seeking jerk, you know? And we don't go to people with like even COPD, people who smoke a lot of cigarettes over time, they get COPD. We don't be like, God, that guy's just here for albuterol again. Like, we don't do that. That's ridiculous, right? But people make choices that lead them to develop chronic medical issues that we as a medical community can help mitigate the problems that come from those medical issues. And actually the science, the true neurology-based science, shows us that substance use is really similar to that. That it is a neurocognitive dopaminergic pathway, to throw out a nice big sciencey word, but process that is treatable. And it's not a moral failing. We are not talking about bad people. We're just talking about people who have really unfortunate consequences to the choices that they've made, but that we can help. We can do a lot. About 46 million Americans, which is 15%, or 1 in 7, 1 in 7 people in the US struggle with a substance use disorder. 1 in 7. Remember, 42% of us know somebody who's died of an overdose, and 1 in 7 of us has a substance use disorder. And this does not spare our seniors. This includes, like I mentioned, every age group. So I want to just point out a little bit this population that I think gets missed a lot. So as of 2022, substance use data usually trails real time. We're always about a year behind, just so you know. So this is actually pretty up-to-date information, even though it looks 2 years old. But in 2022, 6.7% of adults over 65 had substance use disorder. Compare that to 2006, it's double now. It doubled since 2006, so not escaping our senior population. The main substances, though, that get used by people over 65 are going to be alcohol. That's much more common than like injection drugs and opioids and things like that. But alcohol, number 1. Nicotine, number 2. So this is a community that grew up when doctors were in tobacco ads, right? So we're still fighting that one, and I'll take some ownership on behalf of my community for some of that problem. And then the third one's going to be prescription medications, which this is where the opioids for most seniors come from, is actually prescription medication or pill form opioids, and then also benzodiazepines. You might know the names of like Ativan, lorazepam, Xanax, Versed, Valium, those kinds of medications that are really helpful for anxiety. And those can be, they work in your body the same way alcohol does. So we can still build dependence and tolerance and all those things. The number of people over 65 who have been in the last year exposed, meaning a doctor gave you a medicine that could lead to chronic like dependence, is a quarter. Like, what are we doing, America? We're just like throwing out these medications like without really thinking about it. It's really common. And so I want you to be aware of this when you go to your doctor. Like, you should ask, like, hey, by any chance, does this medication have a risk of developing a dependency? Doctors don't always think about that. We should, but I'm being honest, we're humans and we don't. So you're okay to ask that. And then the risk of developing opioid dependence is 7.6% for people over 65. These are not small numbers. And really impressively, they're rising. Yes, they're not, like, we don't see as many seniors out there using fentanyl, but we see lots of seniors using these drugs and developing substance use disorder. More numbers. But really what I want to hone in on this slide is actually more about the alcohol a little bit. So in the past month, 10% of people over 65 in America got drunk. 10%. That surprised me. Maybe it shouldn't have, but it did. I thought that was a higher number than I thought. But like binge drinking by medical definition, 10%. And then when you look at patients who are over 65 who get admitted to the hospital, 30% of them have an alcohol use disorder. If you screen every adult that gets admitted, about a third of them actually have issues with drinking too much alcohol. And of those that go to psychiatric units with depression, anxiety, suicidality, half of them have an alcohol use disorder. This is a really big problem. That's a massive prevalence, right? It's a ton of people. And while opioids kill Americans, alcohol is known to be the substance that causes the most harm. So this is a study from the UK that looked at like all definitions of harm, whether it was chronic medical issues, let's say, for your liver, it would be like cirrhosis or liver disease from alcohol, And from tobacco, it would be like you could get cancer, right? But it also looked at things like complications from those. So did you end up with COPD and asthma type stuff from your tobacco use? Did you get drunk and fall down and break your leg, get a hip fracture? Did you get in a car accident? The cost, the physical cost, economic cost of using drugs. They looked at all those things. And when you look at all those definitions of harm, the most harmful substance out there is alcohol. And alcohol is legal, which makes it really just interesting, right? Like, it's not hard to get alcohol. And yet we know that even the legality was like controlled for, by the way. This is all just like harm. And so alcohol was number one. People always ask me, where was cannabis? You'll see it kind of right there towards the middle by GHB. And then way over here, mushrooms. Yeah. So maybe we should be, that one's actually being studied a lot. I don't know if you're following that literature. Kind of cool. We're starting to study psychedelics as like a PTSD treatment, and there's a lot of promise there. But you'll notice we're studying the ones that are the safest, which is great. But way over here, alcohol, number one, leading the pack, a lot of harm. And during COVID, in case you subjectively perceived this, you were right. The data shows that everybody drank more and started drinking more. Every age group, everybody. We were all at home and had nothing to do but virtual like happy hour with our friends. And so the number of adults that were drinking to excess or drinking more than they should really skyrocketed, and that did include our seniors as well. 30% some of the complications for seniors in general with substance use disorder, and I think the reason that those numbers that I showed you seem so shocking, like how is it that common and I didn't know, are because we actually really underreport this and we don't notice it. Because, when you're around somebody who's aging, we like to blame aging for all of their problems, right? Like, oh, so-and-so's a little more clumsy. Oh, they're getting old. Yeah, so-and-so keeps falling. Oh, they're just getting old. So-and-so keeps forgetting things. Oh, they're getting old. It's time to take so-and-so's license away. Their vision's getting bad. They're getting old. No, sometimes it's not that they're getting old. Like, we're just not asking the right questions. And there are other things that are behind it that are causing the problem. So we are really late on catching this as a medical community and honestly as family and friends. It's often that when we identify it in the hospital and we talk to a family about it, the family is blindsided. People really don't ever they're like, well, I mean, my dad likes to drink, but like, what are you talking about? He has an alcohol use problem. Like, it just really surprises people. And like I said, there are so many long-term consequences. The risk of death in the following 2 years after breaking your hip after you're 65, it skyrockets 80%. It's one of the most deadly things you can do is break your hip. And it's really common to fall and break your hip when you've been drinking alcohol. So there are a lot of consequences that come from these things that aren't just from the substance, right? Like they're actually really bad. And that's people of any age. Like it's dangerous for any of us to be driving a car and drinking or, walking down the road after drinking. The risk factors that we see in this category, though, specifically for adults over 65, is actually males. So that's one thing that gets to go to the men. Usually women are always at highest risk of everything bad. So this is at least evening it out a little bit. Caucasians, people who live alone, right? People who lost their spouse, people who have chronic pain. This one makes sense to me. You take medicines, you build actual tolerance to those medicines. You're looking for other ways to heal your pain. That one makes sense. People who already have an underlying physical disability, whether it's like, decreased ambulation, those kind of movement disorders. If you have any history of drug use when you were younger, your odds of doing that as an older adult are also higher. And then if you are already taking a lot of meds, like if you have, 8 prescription medicines, 10 that you take a day, there's a linear relationship to how many prescription meds you're taking. People who are already taking a lot of pills are more inclined to add more pills or to add more substances because it kind of already fits into their pattern, their habits. And then obviously genetics is always going to be a part of that. What is the most alarming thing is that only 6% of people who have substance use disorder in America are getting treatment. Can you imagine if only 6% of people with diabetes got treatment for diabetes or high blood pressure or asthma or name any? There are more people going on Ozempic than there are on treatments for their substance use disorder, right? This is out of control. I cannot even believe that we are doing such a bad job. And for alcohol specifically, only 1 in 10 patients are getting quote unquote treated, and that's if you include Alcoholics Anonymous and counseling. When you talk about medication, actual doctor gave you medicines to help you, only about half of those people, so 1 in 20 people, are in treatment for alcohol use disorder. And that is what the California Bridge program is here for. We are set out to help hospitals across California, but actually now we've worked with over a dozen states to bring low barrier access to medication for addiction treatment, medication for substance use disorder into Americans' hands, because there are ways to decrease cravings. There are ways to treat, the side effects like withdrawal that keeps people from wanting to go cold turkey or detox. That's real. It's so easy. And a lot of these medicines are really simple. But back when we all trained in the 90s and early 00s, we didn't have to learn this stuff because nobody was dying from this, right? So it's a catch-up program. On the medical side, it's a catch-up program to get all of us there. But when we say treatment, we mean medicine. And why do I mean medicine and not counseling or therapy? Because I told you, when you have a substance use disorder, an actual one, your body physically changes to depend on having some of that substance in your body to feel normal. So let's take opioids as a good example, okay? A lot of you have probably heard of methadone. I think it's a really common medicine people have heard of, yeah? So if you are somebody who has fentanyl use disorder or heroin or any of those things, and you take a bunch of it to get really high, right? And then as it comes down, somewhere in the middle, you feel kind of fine for a little while, and then you go into withdrawal until you get more in your system, and then you kind of go through this awful up and down life on a roller coaster. It's really, 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 really awful. And every time you're at your low, you're looking for your next high because that low is awful. it feels terrible. It's like the most painful thing you can experience. If it's from alcohol, you have seizures and you get like delirious. It's really dangerous. These are actually like deadly withdrawal syndromes. So no wonder people are spending their life trying to get back to their next high, right? That makes sense, physical sense. But medicines like methadone, for example, are aimed to keep people in the normal zone. We give them a dose, not that they're getting high on, but to keep them from just feel normal. Methadone's really long acting. It stays in our system for like just over 24 hours, and it keeps you from hitting that rock bottom point where your body goes into pain and withdrawal. And there are medicines for multiple drugs that are like that. And people will say, well, aren't you just substituting one drug for another? When we do this in medicine, aren't we just replacing heroin with methadone? And now everyone's just an addict on methadone, right? The fact of the matter is that that is wrong. No. What we're doing is treating the actual pathophysiology, the problem that exists in their body. And when we study detox programs, they do not work. They do not work. Over and over and over. This is an example of one from opioids, but we have these for alcohol and benzodiazepines as well. That when you make people go cold turkey, once you get to 30 days after detox, less than 10% of people are still sober. So it's not right to ask somebody who has diabetes to please go lose 50 pounds, but no medicine for you. Figure it out. Change your diet, get your exercise on. We don't do that. We also give you insulin or metformin or whatever it is because we want to help you. We want to decrease the risks of having diabetes. This is the same. We need to stop telling people, go get sober. You're just too weak. Go to detox. Detox doesn't work. The science shows us this over and over. And what about counseling? So I want to be real clear that I believe that if every person in this country was in counseling, we'd be a better country. Like, no question. Counseling is really important. It's so important, and it can be a very effective part of a whole person plan for somebody with substance use disorder. However, by itself, without medication, it does nothing. They have studied this over and over. The literature is actually like really, there were 305 peer-reviewed studies. That's a ton. I don't know why we studied it 300 times, but we did. And it showed that if somebody has opioid use disorder specifically, and you mandate them to go to, say, Narcotics Anonymous or just counseling as a gateway to getting their medication, people do not stay in treatment. They leave. Whereas all the studies that show that if you prioritize the medicine and then you offer people group therapy or personal therapy, you keep that on the table, what you find is that them starting medication gives them time for their brain to just be normal. And some people who are on this roller coaster of high, low, and you're like, do you want to come to counseling? They're like, no, I don't want to go to counseling. I'm in withdrawal. Leave me alone. Like, that's why it doesn't work. We have to give people medicine. We have to let them feel normal. They have to find homeostasis in their brain. And then when they're feeling a little more normal and we've stopped this crisis, now we can talk about long-term health. Now we can talk about counseling and engaging in your community and getting a job and getting your kids back and like all these things that are really complex for somebody whose brain is surviving on the roller coaster of high, low, high, low. That is not a good place to be. And mandating therapy as a gateway to medication doesn't work, and we know it doesn't work. People are not accessing treatment for a million different reasons. Part of it is, for patients who don't have the means to get around, we don't have a ton of dedicated addiction facilities, right? Let's imagine you live here in the Bay Area. It took me 40 minutes in a Lyft to get here from the Oakland airport, right? Like, what if you lived in East Bay and you're trying to get over here to San Carlos because that's the nearest place that accepts your insurance and whatever? You can't expect a regular human who's trying to have a job and a family to make that trek multiple times, right? So it's not just low-income families that have access or barriers accessing care, because there aren't that many places that do just dedicated addiction medicine. There can be long wait times, especially if what you're looking for is a residential treatment facility or rehab, quote unquote. Some people really like rehab, but it's really hard to get in. And you have to have insurance pre-authorization, and again, the lines are long. There are not enough beds for Americans who need this. The places that mandate things like counseling. We have actually seen centers where, and sometimes this is mandated by the county, so it's not actually any individual person's fault. Some of these laws are just old and really outdated. But there are laws that will say, before you can treat that person with medicine, they must fill out this 14-page questionnaire that we wrote in the 60s. And you're like, what? But it's real. These things exist. A lot of these barriers exist. And so one of the things that we do with California Bridge is work really closely with the state of California to find things like this that exist for us and get rid of them. But you can imagine the list is long, and we uncover new ones all the time. In the California Bridge model, we prioritize treatment. Number one, person comes in the ER, let's say they have an abscess. I'm a much better doctor now than I was 5 years ago. I'm gonna be really honest about that. now I know better. Now I know to say things like, how'd you get that abscess? And they're like, a spider. It's never a spider. Everyone thinks it's a spider. If you get an abscess, please don't assume it was a spider. There are no spiders that have MRSA. That is not how that happens. But we all get abscesses for lots of reasons. One of the more common reasons that I see, though, honestly, is from drug use. So now I know to ask in a really open-ended, compassionate way, hey, a lot of my patients that have abscesses do drugs. Do you ever do drugs? And then, because I'm asking in a nice way and I'm genuinely meaning it, and they tell me yes, now we can explore that a little bit, and I can say, do you ever think about quitting? Do you want to quit? Do you want to start medication? I can start you on medication today. We can stop your heroin today. Oh, you fell down, you broke your hip. Why? Because you were drinking? Tell me about your drinking. Let's talk about that. Do you want to quit drinking? Do you want to quit drinking today? Right? So we were missing it. We, the medical community, were focusing on the wrong thing. And so now we're prioritizing treatment from the ER every time you see us. But I'm an emergency doctor. I don't do a good job with like long-term things. I don't know how to adjust medications. I don't know how to be like, oh, this isn't the right insulin. Let's fix it to whatever. What's your cholesterol? I don't know how to do that stuff. That's not my job. I'm like broken bones and heart attacks. And you don't want me being your long-term addiction doctor. That's like a horrible idea. Like you don't want a frequent fly and see me. That's not how that works. And so we also have worked very, very hard to make really strong bridges in our community, to smooth out that pathway for our patients, starting medicine now, but getting to care faster. And so we've done a ton with different counties. We've done it with a lot of nonprofit organizations. Like, and really honestly, anybody who will take our patients and do a good job with them, we will work with you. And we've done that all across. The Bay Area has tons of these, by the way. Highland Hospital is, like, I would say, the state leader in doing this over in Oakland. They are the gold standard, and we look to them. And one of our PIs works at Highland. So we're really, really grateful to all of that influence. But we believe in that connection to ongoing outpatient care. We start the process. We are the resuscitation center. We are the stabilization center, and then connecting you to ongoing care in the community. And then developing a culture of harm reduction. What that means to us is two things. One is getting rid of stigma. It is impossible to take care of our loved ones and our communities when all we think about is words like druggie and addict, and we think everybody who does drugs is homeless on the street in San Francisco, because that's just not true. And so educating to that. And then number two, learning how to talk about drugs, which is really uncomfortable, in a way that is more comfortable. And that's gonna look different for everyone. Obviously, the task for me as a doctor is a lot higher. I have to be able to talk about drugs. I know so much about drugs. I've never used one. I mean that, God's honest. I've never used marijuana. I never smoked a cigarette, like I never have. But man, I know a lot about injecting fentanyl. I just like know about it because I have to be able to talk about it with people. I have to be able to say, if you're not ready to quit, here's where to go when you are ready. I'm gonna send that prescription anyway, in case you wake up tomorrow and change your mind. And also, if you inject, dude, you're gonna get HIV. Could you smoke it instead? Like, these are weird conversations that I never planned to have, but that you have to learn to have with people if you really love them and if you really want them to find their own journey to recovery. The good news, like I said, is that medication works. This is not all doom and gloom. So I mentioned there are several medications for opioid use disorder. Methadone, you all already know. Naltrexone is Vivitrol, long-acting Vivitrol is a medicine a lot of people have heard of. We don't love that for opioids. We do for alcohol, not so much opioids. But the medicine in the middle is called buprenorphine. Sometimes it has naloxone in it. That is a marketing gimmick. Do not let pharma fool you. You don't need the naloxone part. It doesn't do anything but cost more. But buprenorphine, we love. And I actually do want you guys to know about bupe, guys and gals. I want you all to know about bupe because this is something that you might recommend to somebody that could save their life. Buprenorphine is a partial agonist. What that means is it turns on the receptor, the mu opioid receptor, halfway. Methadone, fentanyl, heroin, morphine, those are full agonists. They make you feel high at the right doses, but you can overdose on them. You cannot overdose on buprenorphine. It does not make you feel high, but it stops cravings, it makes your withdrawal go away, and people feel normal for like the first time in their life. And they don't have to go to a methadone clinic every day. They can take a prescription of this to their house, like, here's your lisinopril for your blood pressure, here's your statin for your cholesterol, and here's your bupe for your opioid. Like, it's normal. They have it at their house. It can be once daily dosing. It's so easy. It's an oral medicine. Like, it's so brilliantly simple, and it saves lives. The evidence shows us that it really saves lives, and you can't overdose on it. This shows you a little bit of what I mean. So people who are actively using opioids have a 6 times higher likelihood of death year over year compared to somebody who does not use opioids. If you start that person, that's the blue bar. So blue bar compared to gray bar. If you start that person on buprenorphine or methadone as medication for addiction treatment, their risk of death comes down to 1.8, less than 2 times. This is one of the most massive mortality reductions that any medicine that we have in our arsenal in the hospital that exists. We did a huge study. This is Andrew Herring, actually the doctor over here at Highland Hospital, who we love, one of our principal investigators. We looked at all the research that was done, and we were like, you know what? We're going to do our own study here in California and see if it holds true. And what they did is they took 464 patients who came to the ER who said that they used opioids. And first of all, they offered them all treatment. And what I want you to notice is that 85% of them said, yes, I want treatment today. 85% of them. That's 85% people that we used to say nothing. We didn't say anything to them. People believe that they're like choosing this. They're like, they want to be on drugs. They could get off drugs if they didn't want to be. No, they can't. And we just never asked. We never asked. So 85% of them actually started on buprenorphine in the hospital. And what you'll notice happened is that if somebody started on buprenorphine right now instead of not, they were twice as likely to stay in treatment a month later. That concept has been proven over and over and over, that if you start the medicine now, today, in the hospital, and not like, good luck to you, go see your doctor, start that then, that it doubles their likelihood of staying in treatment at 6 months, actually. So same data. But the answer is, if you ask people, do you want treatment? They say yes. And if you start that treatment, they stay in treatment. And I already showed you that that treatment saves lives. So there is a solution. There's a really easy solution. There's a really safe solution. And I have a million stories about different patients and families that have been positively affected by this, but the overall data, this is how we get out. And you don't have to read this. This is not a quiz on how to start buprenorphine. However, what I do want you to see is think about how complex medicine is. This is a one-page handout that we made that tells a doctor every single thing they have to know about starting buprenorphine, because it's that simple. It's so simple, in fact, patients don't even need us. They can actually start it at their house, like wherever they live. They can start it on the street. They can self-start on buprenorphine. It's such a safe medication. And people always will talk to me about like, well, what happens if somebody goes and sells all your bupe, right? They're going to go divert your bupe. You're going to write these big prescriptions. Now they're going to sell that. Great. Please make buprenorphine easier to find than fentanyl. Please do it, because when they did it in France on purpose, the French, gotta love the French. They do such weird stuff. But they went out there, took a ton of buprenorphine and handed it out. They handed out like tons of buprenorphine, just everywhere. Homeless camps, random people, they just gave it. And what happened was people stopped dying. People stopped dying. The more buprenorphine that was given out, that gray bar going up and up and up, this black one that comes down is the number of people that overdosed. When you flood communities with buprenorphine, people stop dying. So we have to stop making excuses. They don't want treatment. They might sell my bupe on the corner. They don't deserve it. They're bad people. They're all criminals. They're homeless. They're junkies. No, none of that's actually true. The literature doesn't show that. The science doesn't show that. They are normal people. Treatment works, and people do want treatment. For alcohol, we have some options too. Some of these, buprenorphine's the most powerful of all. I'm not gonna wow you as much with any other medicine, but the point is, there are medicines. This is a sample of our alcohol treatment guide that we have for our doctors. There are 2 main medications to know about. One of them is naltrexone. I mentioned this as an injection medicine before. It also can be taken generic, super cheap. It's like $5 for a month. It can be taken as a daily tablet, and it has been shown to decrease cravings for alcohol. It is not the one that makes people sick. So there is a medicine out there called quote-unquote antabuse, which like if you take it and then you drink, you vomit. That's not this medicine. You can still drink, but it makes it just not as fun. It just doesn't feel as cool. Your cravings don't exist. So it helps people cut back a lot on their alcohol use. And it's very safe, which is important. If you take a lot of medicines, it mixes pretty well with a lot of other prescription medications. Really safe medicine. It's only not allowed for patients who are in treatment for opioid use disorder because it's an antagonist. It fights against opioids. So if somebody's on buprenorphine, you don't want them on this. But generally speaking, it's otherwise a very well-tolerated medication. And then gabapentin. Anybody ever heard of gabapentin? It's a nerve medicine, yeah, like neuropathy medicine. It also can treat protracted, meaning like long-term underlying little bit alcohol withdrawal and cravings. So gabapentin has been shown that if you come to the hospital and you're withdrawing from alcohol, We do all this stuff to stop it because it will kill you if we don't. And then once you're getting better, we can send you home on gabapentin to keep your withdrawal symptoms away and to decrease your cravings. So it's also a really good medication. And it's already like a lot of people have gabapentin. It's a very safe, generic, cheap, all the things that we like to hear about medications, and mixes well with a bunch of other meds. Stimulants. Anybody think meth's a problem? Anybody? Yeah, here's the bummer. It is a problem, and we just like do not have good solutions for meth. I'll be really honest with you. This is one of the best ones we have. It's called mirtazapine. It's a antidepressant medication, actually. And patients who take mirtazapine versus placebo have been shown to use less meth overall. So it shows some promise. It's not perfect. We hate meth. It's so frustrating. It's so everywhere. People make it. It's so easy. It's so cheap. Like, this is one where I don't have a mega win. The most effective thing, however, that we have is something called contingency management. So people who use specifically methamphetamine, any stimulant, but really the amphetamine family more than cocaine or ecstasy, like the kind of designer party drugs, ketamine, those ones don't quite do the same thing. Methamphetamine really degrades your intellect over time. It really does. And so people who have very heavy methamphetamine use patterns, their cognition really regresses. It's kind of like dealing with a middle schooler instead of a full-fledged adult. And that's just the effects of the drugs. And so there is a program called contingency management where, I don't know, when I was a kid and I used to go to the orthodontist, like if I was brushing my teeth well and I brought my retainers and they weren't broken, I got a token. And like every 5 tokens, I got a prize. This is a real story. That's contingency management. They did that with me as a middle schooler that had retainers. And it works for adults, actually, like to really just like gamify what it's like to be somebody trying to be in treatment. It does work. And so they'll give patients like, Lyft or Uber gift cards or food gift cards or something like that. And patients have been shown to decrease their overall drug use and actually show up at their appointments when they have amphetamine use disorder when they use this approach. So there obviously people are trying a lot of different things. This is the most successful item so far, but we're all waiting for that breakthrough medication to pop up for us. And then tobacco. 2 main ways to treat tobacco. One of them is a medication called bupropion or Wellbutrin, Zyban. Everybody calls it Zyban, so maybe you've heard of that. And then there's another one that's a little bit newer, varenicline. But these medications help to decrease cravings and also make tobacco, or nicotine specifically, like less exciting. But the most successful way to quit is actually nicotine replacement therapy, and then you taper yourself off. So this is like the gum, the patch, there's lozenges. Nicotine in and of itself has problems. It causes heart disease and things, but cigarettes and chewing tobacco are so much worse. They have like hundreds of carcinogens, things that cause cancer, things like literally they have fiberglass in it to like open up your gums and get the bad stuff in there. So at least by switching to medical nicotine, we have gotten rid of all of this cancerous black tar and like fiberglass and taken that out of your body. And now we can just focus on the nicotine part, get you to still feel normal, and slowly teach your body to taper down off of that nicotine. So nicotine replacement therapy does work very, very well. And even though nicotine's not perfect, I would way rather somebody's on an over-the-counter nicotine gum or lozenge than smoking cigarettes or chewing tobacco. So harm reduction. And like I said, I'd be remiss if I didn't mention harm reduction in general. And when we say harm reduction, I think that word gets misused and thrown around a lot. What we mean at California Bridge is living well. Is that I believe in my heart that every human being on the planet deserves a chance to just like live their best life. And not to be their best self, to be their favorite self, to be the person that they really want to be. And what that is going to be for them, it may not be what it looks like for me. I don't do drugs. I have friends that do drugs. I don't smoke marijuana. I have plenty of friends that smoke marijuana. And that's okay, actually. It may not feel okay, but it's not my job to decide for that person what living well is. My job is to help people not spread communicable diseases, not die when they don't want to die, not get pregnant if they don't want to be pregnant, like things that cannot fall and break their hip when they weren't looking to fall and break their hip, right? That's what living well, what harm reduction is about. So one of the things that exists is fentanyl test strips. These are not as simple as a pregnancy test. They look like one. It's not that simple. If you have, let's say, a bag of methamphetamine, imagine a chocolate chip cookie and then the chocolate chips are the fentanyl. If you test the dough with no chocolate chip in it, you would miss the fentanyl, right? So they're not perfect. A positive is really helpful. A negative, not so much. Lots of false negatives depending on that chocolate chip cookie. They're also technically a little bit hard to use. They can only test liquid. So if you bought rocks or if you bought powder or something like that, to test it, you actually have to like boil it down and do all this stuff. And then, anyway, it's hard. It's helpful if somebody knows how to do it. They're especially popular in like the rave and party scene, where people are just a bit more educated, if I'm being honest about it, and like they're really not trying to use opioids. People will test at home, and the state of California actually sends these out for free, and they're often now located in bigger cities, like in clubs and in the bathrooms and stuff. But they're not the end all be all. I wish they were simpler to use. They're not. They're helpful. They're not perfect. What is super helpful, and something that if you do not have this in your bag at all times and you're somebody who lives in a city, I would recommend it, is get naloxone. You just never know. Naloxone is like the AED or the CPR of 2024. The more people that we have carrying naloxone, the more lives we can save. And we cannot get people into treatment if they are dead. So having naloxone on your person, it's so small. It's like a tiny little thing that you can. I actually gave mine away on the way here to somebody that I met, or I would show you mine. But it's really small, and it sprays in their nose, and we have a ton of it all over now. Like the state of California gives it to ERs to hand it out for free. Prescriptions don't work. Less than 1% of prescriptions nationwide for naloxone get filled because the pharmacies are mean, and there's lots of stigma, and insurance companies suck, which is real. But we hand it out for free a lot of the time. And then if you can, like, never using alone. This is a big thing, right? People are way less likely to drink to oblivion or get hurt if they were with a group of people. People are less likely to get kidnapped and raped. People are less likely to fall down on the subway and not be seen again. People are less likely to overdose and not have anyone call 911 if they're not using alone. So if you know anybody who is using substances or you're ever having that conversation with somebody, there is a national hotline, the Never Use Alone hotline. It was started by a really amazing family after their daughter died. And all it is anonymous. Like if it was me, I could call and say, hey, my name's Alicia. I'm located at this and that location, and I'm gonna smoke some meth. And they would say, okay, Alicia, go ahead. And they wait, and they stay on the phone, and in a few minutes, they're like, you still there? I'm like, I am. They say, okay, have a nice day. Be safe. And they get off the phone. But if I go unresponsive, they send 911 to my location. So sometimes the simplest steps, right, you cannot be in treatment if you are not alive. So our number one goal has to be to keep people alive. I mentioned this, and I won't deep dive, but if you are somebody who would like to become better at talking about drug use, like if you work with a lot of adolescents, if you work with young adults, and you just want to be able to talk about it in a way that sounds confident and doesn't feel weird, there is this organization, the National Harm Reduction Coalition, that has a ton of really good videos that talks about using drugs. And I know that it's like so uncomfortable to talk about using drugs because what you want to say is, don't do drugs. Like, DARE, remember DARE? Like, don't do drugs, and it doesn't work. It doesn't work. So the real goal has to be keep people alive, keep them safe, prevent HIV, prevent hepatitis C, prevent unwanted pregnancy, prevent rape, prevent all these things, right, that are negative and can happen in those circles. And so there are ways to talk about it. This is an example of things I talk about with my patients, how to access sterile syringes, how to clean with alcohol swabs, switching away from injecting, because it just takes the public health risk so much lower. Same thing with alcohol. This idea of spacers, like for every alcohol you have, follow it with a water so that every other drink is not alcohol, then you feel full. Eat food. Eat. It actually helps to not have the effects of alcohol be so bad. Don't drink alone. Drink in a safe space. Don't take your car to the bar and swear you're going to Uber home. You're not. Like things like that. Uber to where you're going to be so you have to take a different car home. Things like that. So we can talk about it with our patients. And what can you do to become part of the solution? It is probably worth knowing in your community, where are the treatment centers? So findtreatment.gov is run by SAMHSA, which is like the National Addiction Medicine Coalition, basically. And it's not a perfect resource. It's not up to date, meaning there are probably more than will pop up. But you could start here by knowing where. I also already mentioned to you that you can go to the ER. I can't promise your experience will be perfect, but certainly if you live here, you can go to Highland. They do a really good job. So you can always take your loved one to Highland if you're worried about that, and they can help connect you to care. If you just want to learn more, especially about resources for older adults, SAMHSA is a government-run website, but it has an entire page dedicated to information about seniors with substance use disorder and how can you help older and aging adults who are having issues with substances, or how can you talk about it, how can you identify it. Get naloxone. It's free. You can get it from these people, nextdistro.org. It's free. I tell everyone, carry naloxone. You never know. Like, the number of people that my friends have actually given naloxone to on the buses or on the subway or on the bar, like, all the time. You just never know. And then I also give it away a lot. Like, if I see people who are using drugs and I'm walking by them on the street, I straight up be like, hey, do you guys have naloxone? Do you need any? I have some in my bag. And then I just give it to them. It is free. So it's a really easy thing that we can be doing. I know it feels like maybe uncomfortable, but if you're comfortable with it, I highly recommend it. And at least have it at your house. You just never know when someone's going to bang on the door and say, hey, can you help me, right? I would hate for that to be the reason they needed my help, and I didn't have it, and it was free. So call Next Distro. They'll get it to you. And then if you want to learn more about the Bridge program, bridge2treatment.org. We're a really fantastic organization. And I'm really, really proud of the work that we've done. I think we have touched so many lives. We have started over 100,000 patients in California on buprenorphine from the ER. That is 100,000 people that used to get nothing, and now they're on, life-saving treatment. But we still have a long way to go. That does not, stop the death rate yet. So we have a lot of work to do. Please learn more about us. And if you want to get a hold of me, you can go to info@bridge2treatment.org. I know that's not my personal email address, but it's better because it'll actually funnel you to the right person. I'm not always the right person. This is a real human, not a bot or AI or ChatGPT. Her name is Kaya, and she will get your email and get back to you and direct you to the right person at our organization. And that's all I have. Thank you. Yeah. Oh, yeah. I can take questions if we have. We do have some. Yeah.
Two quick questions. You did a great job.
Thanks.
Thank you. First of all, with the rise of marijuana among youth, is fentanyl getting into marijuana, or is it going to? That's the first question.
Yes. And?
Yeah. Okay. Second question is, 40 years ago when I was in high school, we were told you're an alcoholic because you drink every day, one drink, and you drink alone. So my friends would drink with their cats, so they didn't think they were alcoholics.
Right.
Now I have relatives that are drinking 2 drinks a day and not drinking with their cats, and they don't think they're alcoholics. So
Right.
what is the rule where you can say you have a problem? Because
Right.
it's changed. Nobody seems to know what that is anymore.
Yeah. So the first question had to do with marijuana. So far, the government, like the DEA, is where we actually track substances. Whenever we recover it from raids or people interact with the criminal justice system, the DEA actually tests their drugs. And that's how we know kind of what's in the drug supply. To date, the DEA has not found fentanyl in marijuana. However, we have a very robust network of doctors that work with youth in California who are telling us that that's just simply not 100% true. But it's not going to be in your straight up doobie joints. It's in like THC distilled, like vape pens. Some of the more exotic forms of marijuana can have fentanyl in them, but we're not seeing it in joints. We're also not seeing fentanyl in marijuana that is bought at a dispensary. So it's still something we're seeing more from the street, which maybe is an argument for legalization. I don't want to unpack that, but it is the thing people talk about, is that at least it's a controlled substance. But they do test a certain percentage of all marijuana that gets sold does get tested, actually, and we have not seen that. The next question was about alcohol. You're right. So we did get taught when we were young, alcoholism is if you drink every day and you drink alone, right? And people were like, oh, I'm going to have a glass of wine with my cat, and then I'm not alone. I'm not an alcoholic, right? But now, what is that? What is an alcoholic? How do you know if somebody has a problem? And it actually has more, there's a lot of screening tools you can use, but the basic conversation is, if that person didn't drink today, what would happen? So if you and that person went out to a movie and there was no alcohol and you came home, do they have to have a drink before they go to bed? If they do, they have a problem. If it's I really enjoy wine, so I have wine with my dinner every day, and I have maybe a glass with dinner and a glass after, and it's a thing I enjoy, but I'm not gonna go to hither and yon to get it no matter what every day. That's not a problem, right? It can be a thing that you enjoy. So it's a lot more nuanced, and it has a lot to do with behaviors surrounding the alcohol usage. Are you able to cut back if you want to? Can you say no if you want to? Will you disrupt other social norms? For example, jobs, showing up on time, community events. Will you disrupt those things to get your substance? That is far more the indicator versus being alone, not alone. I drink a glass of wine alone all the time. I'm on a weird schedule. I'm an ER doctor. Sometimes I'm having it for breakfast because I worked all night. So that it's a little bit more about how it affects your social constructs. Yeah. I would be happy to stay around. Yeah, thank you very, very much for engaging with this. Yeah.